a lot to catch up and learn from our neighbors. So I think this will really assist and probably be a food for thought for lots of us. So yeah.
So in India, it's the whole spectrum.
Yes, I mean, more than 50% of our population is rural based, and if they are not being provided the healthcare facilities, then that is something that needs to be seriously looked at as a priority.
No, absolutely. And I think family doctors are well placed, probably because there is no other clear cadre of primary care physicians. And therefore, the responsibility does lie with family physicians.
Yeah, in UK, as part of my training as a GP, I was told you are the patient advocate. You go to any extent for your patient. When you come to this part of the world and try and apply that, well, I don't know where to start from, because it's a challenge at every step. So by the time the outcome of that, the product, you get to the product, you are deviated and to so many other pathways. And but yeah, it's a learning curve for us probably as well.
Okay, so it's 4 p.m. We'll get started with the session. I'm Dr. RK Prasad. I'm a family medicine physician. I'm also the president of the Academy of AFPI Karnataka, which is the state chapter in Karnataka, and I serve as the chair for the AFPI Primary Care Center for Research for Primary Care Research and Policy. It's my pleasure, along with my co-lead, Dr. Hina Javed, to host this session. We're really honored to have Dr. Pavitra Mohan to lead this session. I'll briefly read out Dr. Pavitra Mohan's bio profile, so you have a sense of the experience, the accomplishments, and just the richness that Dr. Pavitra Mohan brings into this session. So Dr. Pavitra Mohan and his colleagues at Basic Healthcare Services have progressively created a rural primary healthcare ecosystem that integrates clinical practice, research, and learning. They have also fostered an environment that encourages young physicians to challenge the inequities and assume leadership roles in rural primary healthcare space. In this seminar, Dr. Pavitra Mohan will share his own journey and experiences of assuming and inculcating leadership for transforming rural healthcare. Dr. Pavitra Mohan is a community health physician. He's a pediatrician and a public health practitioner. He is the co-founder of Basic Healthcare Services, a not-for-profit organization that provides low-cost, high-quality primary healthcare services for the marginalized populations in southern Rajasthan. Earlier, he used to be the senior health specialist at UNICEF India Country Office. He has designed and led large-scale health programs to improve maternal, newborn, and child health in India. He earned his MBBS and MD in pediatrics from Delhi University and a master's in public health from the University of North Carolina at Chapel Hill. For his contribution to newborn health, he was inducted as a fellow of the National Neonatology Forum of India in 2010. In 2018, he was awarded the prestigious Ashoka Fellowship for Social Entrepreneurship. Dr. Pavitra Mohan, our honor, and please, over to you. Thank you.
Thanks so much, Dr. RK Prasad, for that generous introduction, and thank you and Dr. Hina for inviting me here. I'm really pleased to be here today, and I'm pleased for two reasons. One is I'm kind of interacting and speaking with a group of family physicians, which I aspire to be, and and a disclaimer here that I'm not a family physician, but I really admire the discipline and the student there. I'm also happy because I think this is a cross-nation kind of a series where there are colleagues from other countries in the subcontinent, which itself is a big boost for me. I mean, I'm really pleased to interact with my colleagues both from India and from our neighbors here. There are both in India as well as in, I presume, in other countries of South Asia, there are huge inequities in healthcare, right? On one hand, for example, in India, there are state-of-the-art hospitals where you can get probably the most modern robotic surgery done at the, I mean, if you have the money. On the other hand, even if you have a treatable condition like tuberculosis, you may have to wait for months to seek care, and many times you would get indebted. Um, I was, once in a conference where I was invited in a management school which offered healthcare diplomas, and a CEO of a large hospital there was boasting that how his hospital has been able to reduce the time taken from the time a patient enters the door to the surgery and to the opening up, and that it has reduced from 30 minutes to 28 minutes. And I was wondering that in areas that we work in, it takes a person with a condition like diabetes probably years, if not many months and years to actually reach and seek care if the person is lucky. So such huge inequities really make you wonder. And what I would do over next 20 to 30 minutes is to to share some of my, that's what Dr. Prasad asked me to share with you of my own experiences of how I and basic healthcare services have sought to address some of these inequities at different levels. About 10 years back, some of us who had been looking at these inequities closely and had been part of the health systems, looking at public health systems very closely, were really disturbed by the fact that access to healthcare is absolutely pathetic in many remote and rural parts of India, especially. At the same time, there were several things happening in the country which was increasingly improving the care and the quality at cities, in larger towns, but in remote areas across the country, irrespective of the the development status of a given state, whether it was Tamil Nadu or Andhra or Karnataka or rural Bihar. In remote areas, people were really left to fend for themselves. And we also realized that there are no easy answers. The infrastructure is, very inadequate. It is difficult for people to live and work in such areas. Social beliefs and customs are highly, they're so deep entrenched. All of it makes delivering healthcare in such areas difficult. We realized that there are no easy answers, and that's when we got together to set up basic healthcare services and clinics called Amrit Clinic, like the one that you see here. It's a picture from about 9-10 years old. So the idea was that can we use the principles of primary healthcare to provide responsive healthcare with dignity at low cost and of high quality in populations which are remote, rural, and who have very little access to healthcare otherwise. We realized that the normal progress at which health systems are improving in country is unjust. It would never reach some of these areas. We also believed that besides the principles of primary healthcare, that is, they have to be based in the community that we are serving. It has to be with their participation. One is to use the best possible evidence and use of appropriate technology. So some of those kind of core principles of primary healthcare is what we started with. We didn't have all the answers. The other thought that came early on was that nurses are a good primary care provider, and they're not only in absence of doctors, but even in presence of doctors, a large amount of healthcare can be more compassionately, more relatedly provided by nurses who are qualified, who often come from similar rural and tribal areas. Especially in India, in last decade or so, a large number of girls from rural and even remote tribal areas are going on to become nurses. And we realize that nurses could be at the center of these clinics, while community health workers and volunteers support them on the ground, and a physician supports them with referral support and with teleconsults. So that was what was in our mind, and we translated this into what we call an Amrit Clinic, something like you see here. One of the things we realized many years ago, in coming back to the integration of research and practice, many years ago, about 20 years ago, in the same area, in the same district, we had conducted a study where we tried to look at why some ANMs or some nurses reside in the work area in rural areas, while other actually do not reside. They often reside in a city and do commute daily or weekly or monthly to their area of work, which usually affects their effectiveness, right? If you don't live in the communities and only commute, it takes huge effort and time to reach and then connect with the community reduces. So we've tried to find out what are the reasons why some ANMs or auxiliary nurse midwives do reside in their work areas while others don't. And we found that those who were more had a more rural background and those who were themselves likely to be more from an indigenous community or a tribal are more likely to reside and work in such areas. So building on that evidence, we increasingly have been, with an affirmative action, trying to find nurses who themselves come from a rural background, which helps them empathize with the community and settle down much more easily than those with the urban bred girls. And this is a short film of about 90 seconds on the clinics. It was made many, many years ago, but it is still relevant in the in understanding what Amrit clinics provide. So I'll just start it and let you see this. Buzz, you can see.
Yes, we can see the video, but is there a sound to it?
Dr. Pavitra, you are muted. If you could unmute yourself.
Hello. Yeah. Can you hear me now?
Yes, yes,
Yeah,
we can hear you now.
Okay. Yeah, I think the host did not allow me to speak in between. So that after we had run these clinics for a few years, we were trying to understand what do we do next. How do we enhance the impact of what we are doing? How do we do things better? And we were talking to a large number of people across the country, and one of the most important one was Professor M.K. Bhan, and probably people from who are viewing it from India, many of them would know him. He was one of the finest pediatricians and a public health expert and a scientist from India, but had made global contributions in several fields, including the use of zinc in diarrhea and the rotavirus vaccine, etc. So he advised us to generate. He said that you are already on the ground, and you're seeing a lot of things that others don't. You're deriving insights by doing. And while in general people use the evidence, use the theory for practice. That's what you start with. But when you're seeing more and more things on the ground, you developed insights. You must try to start converting them into theory. We didn't realize that we understood him correctly, but we tried. Many years ago, in fact, I'm going back in time when I was about to enter the field of public health, when Dr. Bhan at that time had advised me to go and study public health before you go on and try to do something closer to the community. He said, you're not trained in it. And I was wondering, that I was already an assistant professor in a medical school here. I said, I've done my MD. Why do I need to go back and learn another thing only to work with the communities? But I took it on I took his advice and went on to study public health. And after coming back, I happened to lead a large kind of a research trial which was to look at how in primary healthcare centers in rural Rajasthan, if you train them in counseling, does that improve their behavior, and does it in turn improve the care-seeking behavior of the families that they come in contact with? So that study was interesting, but what was more interesting was what I tried to analyze it separately from the same data set. One thing that was very striking, it was very commonsensical, of course, but what struck me was that for a simple service like vaccination, where you live is very important. If you're living far from a health center, your chances of getting a child immunized is much lesser. It makes sense. You need to carry the child. Mother needs to walk half an hour to reach somewhere, and compared to something that is available closer by. So that kind of, and we also analyzed in that data set that who are the people who are living far from health center. These were the ones who were the poorest and who belong to an indigenous, one or other indigenous tribe. So the poor people live far from the health facility, and therefore they are much less likely to get vaccinated. So that was something that struck me at that point of time. And based on that, based on that, subsequently, I went on to work with UNICEF, and using and keeping this in mind, they developed a vaccination program across the state, which was to ensure that there is a vaccine point available within half an hour of every household in the state. So it was basically meant a lot of planning to ensure that vaccine is available much closer to families than it ever was, and that became a plan and on a fixed day and a fixed site. And within 5 years, that led to a huge improvement in complete vaccination coverage of the state. It went on from, I remembered in 2004, it was around 24% and went on to 48% in the next 4 to 5 years. So that was where I really realized the value of research, the value of insights that you gain from the ground, but also of rigorous research and applying it for an intervention to improve healthcare of people who live in remote areas who are underserved. I moved on, and while in UNICEF Delhi office, where we were setting up newborn care units across the country. And one of the things that was worrying us was that while it is easy to start an infrastructural project of setting up newborn care units, putting in a lot of equipment, in country like ours, it is usually difficult to ensure that there are adequate number of skilled human resources to manage a new initiative like this. On one hand, we were convinced that having them in district hospitals would significantly improve the neonatal mortality rates. But on the other hand, we were worried that the required number of nurses would not be provided by these health facilities, leading to failure like many other similar initiatives. So very early, we tried to analyze it from the first 8 units that we had established to demonstrate that where there was larger number of nurses or a better bed nurse ratio, the mortality rate was much lower. And that helped us to set standards of number of nurses. And that evidence really helped across the state and across the country to ensure that adequate number of nurses were provided. And at the moment, there are more than 500 such units across the country in rural districts, and each of them have adequate number of nurses. Again, kind of helped me realize the value of researching while practicing, whether it was a public health practice in this case. Coming back to where we are, when we started the clinics, and after and we being pediatrician, I mean, some of us who started the organization were pediatricians, and we understood childhood malnutrition very well. But the levels of malnutrition that we were seeing in the clinics was really huge. And what really struck us was that there were even the adults, the men and the women, were also fairly malnourished. And in children in general, it is commonly understood that childhood malnutrition is predominantly because of the childcare practices, and mothers don't know or the parents do not know what to feed the child. But what we were seeing here was that if adults are also malnourished, it cannot be because of practices. We in general say that India is a food replete country and therefore access to food should not be a problem. But that's not true. India is always is a land of contradiction and multiple kind of identities. In areas like ours, the food access was really a problem. As you can see here, that when we asked that what food item was available, only 14% had any vegetable available at that point of time. Fruits were available with only 2%. Virtually nobody had eggs or meat at that point of time. So that made us really wonder that you can't improve malnutrition by training people on what to feed because there's no food. And we also found in the same study, which we published later in Economic Political Weekly, that that mothers also had very little time because these are also areas with very high levels of out migration. Men are just not there. They have gone to cities to work, and women are left behind and have absolutely no time for childcare. So in absence of food and in absence of time, the children continue to be more and more malnourished. That's what helped us. So this kind of understanding helped us set up what we call as fulvaris or daycare centers or a bed of flowers, where children are both, where mothers can drop their children, do their own chores, rest for a while the children are provided play, food, and learning opportunities. So this helped at least amongst the children that were enrolled in these creches over the last 8-10 years. Malnutrition levels really almost, the severe malnutrition disappears completely, and malnutrition levels also drop significantly. We also found a huge improvement in their abilities, and then they do much better in schools than other children. So again, I think something that we were seeing on the ground, which was high levels of malnutrition, non-availability of food, and then converted it into an understanding of what can be done to improve nutrition levels. We are now at the next phase where the challenges become more tough, right? And now we have, say, 15 fulvaris, we serve about 500 children, but then what about all other children living in? How do you really scale it up? That's where we are at the moment. That can such care reach every child who needs it? And that becomes a larger kind of a problem to solve, but an important problem to solve. And I think any discussion on primary health care in these days, after a large pandemic that all of us have gone through, would be incomplete about realizing that how in rural areas COVID devastated large populations and how unprepared we were to manage it in general. And I'm talking of everyone here. But one of the things that we were, when COVID started and we were sitting in these remote clinics, we had not started seeing the patients suffering from COVID, especially in the first wave yet. And we were wondering, there was this whole discourse about ventilators, about intensive care units. And here we were saying that, come on, who's going to manage these ventilators? How are people going to ever reach an intensive care unit from these areas? What we realized what was really required was oxygen. We said that if we also reviewed evidence from Italy and other countries where COVID had reached earlier, that most of them required were mild, were moderate COVID, which would have improved. Most of the deaths could have been averted if oxygen were available. And with intensive care, even in the best of settings, the mortalities were pretty high. So for a country like India, we realized that this focus on ventilators and ICUs was misplaced, and what was really required was access to oxygen. And that's when we wrote intensively, we advocated extensively about the need for oxygen concentrators. We procured them very early in the first phase itself, but also were continuously advocating for it, which kind of motivated a few large philanthropic organizations to procure, like this paper here, which we wrote. Actually, this paper is written on 28th of March, so about 7-8 days when the COVID was, when the lockdown was announced in the country. And but sheerly what we were kind of reflecting on and seeing in our own areas led to a large number of organizations then pre-positioning concentrators. And one of them actually supplied the largest number of concentrators across the country. And by the time the second wave really hit, people understood the value and something that what we were seeing on the ground and experience with became useful. Though, of course, the misery that COVID pandemic still led to in most parts, including in rural India, was something unprecedented. But I think just the pointing to the need for oxygen and oxygen concentrate at the right time did help to some extent. We also see, large number of babies, newborns, children who, if the good quality primary healthcare was not available, they would have no means to reach a city hospital, right? I mean, this newborn here, a low birth weight, would never have been able to access a city hospital or a city nursery or even a district newborn care unit. With a combination of indigenous continuous positive airway pressure and followed by kangaroo mother care, this baby was saved. But of course, not how do you really ensure that it reaches everywhere? How do you use technology? So kangaroo mother care is a beautiful technology that is empowering, does not require much training, etc. There's no cost involved, there's no power, there's no bandwidth involved here. So what should be the attributes of technology that primary healthcare really requires in remote resource constrained settings is something we started reflecting after seeing this baby. And similarly, some other cases. So based on some of this understanding that we were gaining by doing and by reflecting, so we started at BHS, we started a quarterly column in a new journal of Indian pediatrics where we share some of these case studies and also then reflect in the end on what would its implications be for policy, for technology, and for programs for healthcare. This I thought was a bit close to what Dr. Bhan had advised us. At that time, we didn't understand fully that can we convert some of what we are practicing into theory. At BHS, we are also very proud to progressively creating an ecosystem where people practice, investigate, reflect, share, and convene. Primary healthcare in rural areas is a tough job for many physicians, for public health professionals, for young professionals of different kinds who make the healthcare happen in these areas. And for them to learn, to reflect, to be in an ecosystem where that is promoted is really important. It's also important, and not only important, but I think it's a duty in many ways of people working in rural primary health care to share what they are seeing, what they are reflecting on, what they are thinking of, because a large populations, large number of doctors and practitioners do not ever see that reality. So in some ways we are we are a channel to share what is happening in these areas, and it becomes a responsibility. And I'm glad that increasingly BHS with colleagues, you can see Dr. RK Prasad there, and other colleagues who convened, for example, this panel on rural primary healthcare and what does it mean for young physicians. How more and more physicians can actually take up rural primary healthcare practice, rural primary healthcare research and leadership as a career option is what we discussed in this particular panel as an example. And also have fun, right? I mean, and I was there. There's one young physician who just completed a fellowship with us, and she shared some of these pictures and said that what she learned during these 3 months, that all this can be done with a lot of fun. So I wanted to share some of these pictures here. So far I've tried to share based on some of the experiences that I've had the opportunity to have. Is that how you can integrate practice with research, whether it is a public health practice or a primary care clinical practice with research and vice versa. What I have not spoken about and what I was invited to speak on is about leadership, and how can primary care physicians and other primary care professionals, how can they assume leadership, and what does it really mean? And to me, I think leadership is a bit of a presumptuous word, and therefore I was a bit uncomfortable when we were discussing the idea of this seminar. But if it is meant to influence for a social change, influence to reduce some of those inequities that we talked of, then it is worth it. And that kind of helped me reflect. And I found that the concept of what we call as servant leadership is what is probably closest to what doctors and family doctors and others and public health professionals can aspire for. Question is, why do you want leadership? If it is to influence social action, then it is to serve. And if that is the motive, that is the goal, that's the end, then people will find out their own ways to get there, right? I mean, how is not so important. Most of the management literature is full of how do you become a leader, but there are very little which says why do you want to become a leader, right? I mean, and I think if you can answer that why, how is relatively relatively easier, I would think. What still the question remains how, and I think that depends on individual strengths. But one of the things that I have found useful, that how do you influence for us as professionals, as people of science, I think one of the strongest way to influence is through knowledge, and that knowledge is generated through practice and research, right? You would have seen in whatever I've shared so far, some of the snippets, is that the way I have, reflecting back, wherever I've been somewhat successful in influencing, or we as an organization have been somewhat successful in influencing, it has been largely through knowledge. It has been through evidence. It has been through experience. It has been through reflection and writing and sharing. So if servant leadership is the why of leadership and thought leadership is the how of it, I think that to me appears to be an interesting and a possible framework for many of us here. RK did say that you must share this, and therefore I'm sharing this. And I think besides that, all of the rural primary healthcare practice does get stressed. You see a lot of misery. There are many times you can't do anything about that misery. Sometimes you do, and you feel happy about it. And therefore, having some other interests where you can find the truth, you can read what others have written, being closer to the art is important. And I personally love reading and translating, and this is one recent work that I translated, which is based on the partition of sins, and I shared it here, and I think that's the reason why RK wanted me to share it here, is because it concerns more than one country here. And and if anybody wants a copy, I'll be happy to share. Finally, I think, how do you put all of it together? And I find this quote by Bertrand Russell very powerful, and something that has helped me quite a bit. That the good life is one that is inspired by love and guided by knowledge. So the love is the purpose of I would think life and leadership, and knowledge is the means to get there. If we, I think, keep the love and the knowledge in our front, I think that we'll be able to integrate our life, our work, our research practice, and we can influence things for positive action. Thank you very much.
Thank you. That was impressive, enlightening, and I think it's a motivation for all the listeners. It was certainly for me. You've done a marvelous work, no doubt. I've got a few questions, and then we'll open the floor for questions. This is a multidisciplinary effort, isn't it? The first question is, how did you manage the other team's engagement? What was the funding like? Obviously, we need finances to access the remote areas. And did you notice any behavior change after these activities within the population and also within the policymakers? Thank you.
Thank you, Dina. That's a difficult question. It's several questions, and I would probably start with the last one. So I think so behavior change is something that I think when we go from cities, we presume that the desired behaviors as we understand them would change very rapidly because you are there, you are talking to people, and why don't they change? Right? But there are several reasons why people don't change. They have their own livelihoods. I mean, you ask a woman, for example, to take oral contraception, but there is no access to contraception in that area. Or if the husband sees a woman taking contraception, he might beat her. So things like that. Having said that, I think just the sheer continuity of services for a long period of time with the right intent, with continuous and consistent messages, does change behavior usually. For example, in one of our clinic areas where when we would go out to households of women, they would still not come out for antenatal checkups. But now many of them walk 7 to 8 kilometers to seek care. At the same time, whether the status of women has changed in those 8-10 years, it probably hasn't to the too much extent. We still feel miserable when a woman with 4 grams of hemoglobin, when we need to refer her, but the family refuses to take her. So I think one has to be patient, but also be consistent and continue to provide services for a long period of time. It is a long, because these are historical injustices and inequities of hundreds of years. It's only by, and I think people have also faced a lot of mistrust in the past of people coming from cities and talking about this and that, and then either going away or fleeing away or whatever. So I think a consistency and as I say, that to be trusted, you need to be trustworthy, and that takes time. So that was about the behavior change. About the policymakers, I think in India, and I'm sure it must be same in Pakistan and in other South Asian countries, we are cut from the same cloth, that there is no straight path to policy change. And I think one just has to be prepared for with the right evidence, with the right details of what you want it to happen. And if the time is right, I think then things change. For example, I remembered that the first time when we went to a senior bureaucrat in Delhi to say that these are newborn care units, these are great ideas, we're already implementing it in 3 to 4 districts. He said, get out of my room, these are expensive things, we can't afford it. And a few months later, just because the time was right, there was another bureaucrat and it kind of went off. So I think one can't, it's not a linear progress in India in policy making. One has to be just prepared and consistent.
Thanks. Right.
About funding, I think in general, I feel that it's really secondary, and I'm not saying that as a cliche, right? I mean, I know it is important. Without money, things don't move. But at the same time, I think if the work is right and you're determined, the details are fairly worked out. To us, we have had sleepless nights because we didn't have money to spend, to keep the clinics going for the next month. But there have been fewer periods like that. But that has never kind of restricted our functioning. And I'm saying this with all humility, I think, and I've seen many others that once the effort is right, yeah.
Yeah. So, Dr. Pavitra, thank you so much. Really inspiring talk, rich in at so many levels. I have a question regarding how you went about building your team, because obviously I know that 2-3 of you were pediatricians who started as clinicians, but then to be able to serve an entire district with 7 to 8 clinics requires you to build depth within the organization, nurses, other health professionals. How did you go about building your team, and what were some challenges you encountered, and how did you overcome them? Thank you.
So, I think one is probably, I think one has been fortunate to have wonderful people joining in and then believing in the work. So I think some of it is probably just sheer good luck to have good people around. And some of it remains a struggle, right? I mean, to have consistently a set of people who deliver on the ground and who are not affected by what is happening. Because, there is a lot of peer pressure or to work in cities or work in corporates, or and many people who would have potential to work anywhere else in the world, right? I mean, but to consistently work in rural areas, I think so. To my mind, I think some of the things that have worked to a large measure in our cases to build, and that's the effort, right? I mean, it's a continued effort. It's always a work in progress. Is to build a culture which is supportive, which understands people's needs, and which also keeps the goal in mind, the empathy for the communities that we work with in the mind. There is also, I think, a consistent effort required to help people exposed to different perspectives, interact with different points of view, and also an opportunity to grow. I think some of those factors of looking at individuals with their kind of need for growth and development is important. Creating a culture of service and creating a culture of connecting with the communities is something that is extremely important. Having said that, there are a huge pull factors of different kinds that people have, and which also we appreciate, and we feel that somebody, for example, there was this excellent nurse we had who worked with us for 5-6 years, and now she got a government job, and she's now working as a community health officer in a small area. And very recently, we came to know that while everybody else in a community health officer is still trying to struggle and not fully understanding the nature of job, this girl is already kind of probably running an Amrit Clinic on her own. She understands the comprehensiveness required for delivering services. She understands the empathy required in the skill. So we are happy that people then, when they move on, but to invest in people's growth and development is, I guess, important.
I think there's a question in the chat box with some comments. The question that I can see is, how have you been able to encourage communities to take responsibility for their health? So people empowerment, basically.
So I think there are several set of questions from Roshin, and I'll try to address. One of them is about communities, and maybe I'll start there. And I think, Roshin, it's a good question, and it's a difficult question as well, because I think where communities have so little resources, so little time, to expect them to usually take responsibility of their own health is never going to be easy. There are multiple claims on their time and on their lives and on their resources, and therefore they would prioritize what they find rationally at that point of time. For example, if it is rest during pregnancy, or is it working in the field because you don't have food if you don't go to the field. So things like that. Having said that, I think there are several ways, and these are common ways in which you try to promote community participation, is having a community interface through community, building a cadre of community volunteers, empowering and engaging them on a regular basis. Having all of our clinics have a community advisory group, which has members of the community that come together every 3 months, review what we are doing. They push us, we push them. So those are some of the ways to promote education itself. Creating awareness about your own health on a regular basis is also important. One of the most kind of gratifying thing which works almost consistently are the fulvaris, where children, when children go back from fulvaris, they ask their mothers that, we want to wash our hands and please get us soap, and you also wash your hands and stuff like that. So I think the greatest behavior change and the greatest kind of empowerment happens at that age much more than any other. So we are most kind of, if we can claim some success, it would be in influencing people's behavior. It is much more at that level because they have the whole life ahead of them and their mind is more plastic. That's where some input leads to huge changes in how communities start taking responsibility for their health. There was another question, creating parallel systems. So I think, Roshan, that in India, and I feel that in underserved areas anywhere in the world, whether it's the jungles of Amazon or wherever else, or the hills of the mountains and of NWFP, I think there can never be duplication, right? There are such crying needs. Even if 10 organizations and government and everybody come together to work in one village, it will still be inadequate because there has been so much of there are such huge unmet needs for healthcare, right? So I've never been tempted by this question, and I've never that. Are you creating a parallel system? There is always a huge scope. For example, if a public system that's close by, in one of our clinic areas, there is a primary health system run by a government facility, which conducts deliveries, right? There's a popular nurse there who's been conducting delivery, and a lot of women actually go there for conducting delivery. It's not a competition. So we encourage, the antenatal care. We conduct the PNC visits while the deliveries happen there. So there is always scope for huge collaboration and working together to meet the needs. I think as long as you keep the needs of the people in center and not on being either competitive or who else is there, there will always be a scope to work. You should, of course, consciously ensure that it is collaborative and not affect adversely in any ways the population that you're serving. And there are various ways in which you can work with the public system, but there are also a value in not work. I think what is important is when you decide not to work with the public systems also at times, right? I think it gives you flexibility, it gives you ways to innovate, but also when the time is right, do it in a manner that that's kind of synergistic. So I think public-private partnership is useful, but not necessarily always. And there is a value of private initiative, which is absolutely private and where you don't want to be bothered by any kind of pulls and pushes or bureaucracies. Uh, So the question from Parvati is that how do you address mental health? And thanks for asking this question. And some of us on this call know that how desperately we want to start responding to some of the mental health challenges. We are actually right now trying to, the problem with primary healthcare is that there are multiple dimensions and multiple needs. And you don't have a luxury of having, probably not, shouldn't say even the luxury, it's probably not the right in any case, but to have the specialized inputs to create any new initiative. For example, we started with child health, we added maternal health, we started learning about tuberculosis because that was the need. We added hypertension, diabetes into our work. We added the referral services, etc. And mental health increasingly is appearing an important area of our work. We are facing that on clinical sense. We started treating some of the patients with mental health, but we realized that that's only a very small part of what we need to do. And therefore, right now, we're in the process of curating a program that can integrate with the primary healthcare. So the problem in primary healthcare is that if something is very heavy, right, you start with a mental health agenda, then everything else can get offloaded because it's the same set of people on the ground that are delivering those services. So how do you integrate it beautifully without disturbing is important. Therefore, right now we are at a stage where we are trying to create a mental health program which gels with and integrates with the rest of what we do. Bhavya, we are aware of the MH gap tool of WHO, and it is also one of the things we are considering. We still have to figure out how to fully integrate it.
I just have one follow-up response or question. Thank you, Dr. Pavitramon. I actually met you 5 years ago when I came to Ajivika Bureau. I just enrolled at LSHTM for an MPH and recently finished it, and I'm working in the mental health space. My question, just sort of a question or a thought to you is, do you train, like you have trained community health workers to address other primary health issues? Is your plan to also train a group to work on common mental health illnesses that is probably endemic to the demography that you work for?
Yeah, I think from what is emerging from our initial kind of exploration is that's the way to go. We want to keep it much more of a community-based intervention and also focus much more on prevention and promotion rather than focus on treatment. So yeah, hopefully that's the path we are likely to take. Our initial kind of exploration has reaffirmed that's the way to go. And would be good to stay connected, Parvati, to also discuss that more.
We have colleagues from other countries as well. If they would like to give a comment or ask a question, then please feel free to do so. I can see Dr. Basharat is here. Sir, if you want to say a few lines or any comments with regard to the research work, I'm sure you've got a lot of experience in that due to holding a PhD. And I can see Gobit Ratnam from Sri Lanka. So if you would like to ask a question or say a few things. I'm sorry if I've missed anybody else from the regional countries. So thank you. Gobit, are you with us? Or Dr. Bisharat, if you would like to say something. You have to unmute yourself. Right. Gobit, do you want to unmute yourself and say a few things? I know you've been working in rural health as well.
Yeah. So good afternoon. Actually happy to listen the great talk about this, how this community in rural setup has developed there.
Yep.
Actually, we also had the same experience how we develop one of the community in the rural and remote area. I developed through the community-oriented primary care project, like same maybe that maybe community participation and all behavior changing model. To here as also thank you for the sharing this knowledge. I can add actually that we may think we may in the as we always think we may have a lot of work there. Maybe the we have busy in the morning to evening, but still having the or documentation, maybe the research and data, everything's very important to share with others. And how can we show the world so how we can work and how can we in a way in the research is important here. So start from the beginning, maybe with some even for the practice setup or some small auditors, whatever that, then we can go with even with a bigger research like the immune system or even all the model like that. Thank you.
Great, thank you.
So, can I have some message, please?
Yes, please go ahead. Yeah.
Yeah. Thank you very much.
Just introduce.
Actually, the research and the work in rural areas is always challenging. Challenging in the both sense. People are not usually cooperative. They have to be trained for that required result. We have to reach them more for the many time to have the required result, and they want to have these services in a very good way. Then they can help us in research. But we want to take the data from those people who have to make them understand the need of the day, the need of the patient, and what we can expect from those. So it is always challenging to work in rural area and to have the research there. But you know, the constant work and effort can always have a good results. So we never get tired of the work in the rural area. Do you have to go many times to them, to approach to them, then you will have the results.
Yeah, that's correct. Be consistent. Yes, thank you. We have a question in the chat box, how you manage domestic violence. Oh God, that's a good question. Is there any resource or whether any research done on it?
I think that's an excellent question, and it concerns probably all of us here. So we had been seeing the cases of domestic violence amongst women who visit our clinics, and that really, but what really, when we really become really sensitive to it was after COVID. We started seeing many more women coming out because there was a larger, as I said, these are areas with large number of men who are migrant and they stay in cities. But after COVID, many of them after the lockdown, they came back in their prolonged stay here. And that exacerbated the domestic violence cases in the clinics. So I think at that time we built our understanding of ourselves and our clinic teams in being more sensitive and how does one respond to it. In some cases, we had to seek a kind of a legal recourse or or a recourse of separating the woman in question because there was an excessive We also work with a partner organization that works on the issues of migration and livelihoods very closely in these areas. And they have a whole program around family empowerment, which works with women and women's collectives. And there was also kind of an exchange of thoughts and ideas on how to tackle that. And they've also taken that up as a very significant agenda post-COVID, these women's groups of addressing domestic violence through action by women themselves, other women in the. So it is an important kind of an area where, like many other in these areas, where there is such a gender inequality and discrimination of women per se, which reflects in. I would say that we've become more sensitive and responsive. We try to understand the situation and interfere at the family level, and with our partners try to see legal recourse and others.
Okay, great, thank you. Right. Any other hot burning questions? Okay. What opportunities for social entrepreneurship, micro entrepreneurship do you see in rural health?
So I think if entrepreneurship is about finding solutions, the space of rural healthcare is really open. I think if that's what we understand by entrepreneurship, that the rural health space is crying for solutions, right? I mean, for example, a simple thing like an X-ray. In rural primary healthcare settings, X-ray is such an important tool, but the machines that we have are not fit for being used in a primary health center because of electricity, because of the regulations around it, because of the way that they are heavy. Similarly, ultrasound. Now, ultrasounds are available, which can be used in the primary healthcare settings. But in India, especially because of the preconception, diagnostic rule, you cannot use ultrasound, and therefore the access to ultrasound is extremely limited in rural healthcare settings. So all of these are, these are technological solutions, but there are also many systemic challenges that are trying to be solved. And therefore, I see that there is a huge ground there. Question is, how does it become sustainable? I mean, how does an entrepreneur make his living while doing all of that? And that's a question I think we need to really crack, because we need solutions much more than in cities. Every health technology or every new development happens for the rich, for the cities, for people who can pay. But why, just to have that technology, those solutions for rural areas, for primary healthcare settings is so essential. But often, the entrepreneurs typically are not able to work consistently for rural primary healthcare because there is no money to be made, right? I mean, at least in the short term. And that kind of ultimately demotivates many of them too. So I think we have to create an ecosystem where designing rural solutions is in some ways incentivized. There's no dearth of solutions. The other thing I think one needs to, which I kind of always emphasize, is that the solutions have to be in response to the problem there, right? I mean, many times the entrepreneurs come with a ready-made solution. It's like, you have a key and you're trying to find which lock does it fit in, right? So you have to really find that what is the problem and then find solutions, and there are plenty of them, and it can only be done in partnership with a person who wants to provide solution and the practitioner together. Many times these are done in isolation. Technologies are developed by technology entrepreneurs in isolation, and then you try to retrofit into a problem you're trying to find it. So I think these two things are important. That one, creating an ecosystem where the rural solutions are incentivized for an entrepreneur to ensure that they stay in the game for long periods. And the second is to work in partnership with practitioners on the ground to understand the problems in them.
Dr. Hina, can I add to this topic for a few words?
Yes, please go ahead. Yeah.
We have a basic unit system, then rural health, then THQ and DHQ in Pakistan. And what we need is just to train the MO, the doctor in the BHU and the RHC, rural center. You should be trained enough to deal with the patient of the family medicine or the primary care. He or she should have some interest in certain field of life. Maybe some lady has interest in gynae, some male has interest in some other. So we should create the GPs with special interest. And these interests may be in ultrasonography, in gynae, in eye, in ENT, whatever they have. So we can have very good then result then if we can be able to this. Moreover, the GPs in the rural areas like neuro RSC, they should have access to the rural center for the tests they have been done there. The patient can take the advantage of the test available in the rural centers, other THQs. So we can have the better results then.
Okay, some great suggestions there. Yeah, GP with special interest. Yeah, we can work on it. There's a question from Japan. It's a student of pharmacy asking, what kind of ability or role will be required for a pharmacist working at this level of rural area? So,
no, thanks for asking that question, Yuya, if I get you correctly.
yeah.
So I think there is a, I think it was you, Hina, who said that it is a multidisciplinary work. So primary healthcare is really a multidisciplinary. And I think one of the biggest problems, at least in our part of the world, has been over-reliance on doctors for improving healthcare in general and for rural healthcare especially. It is a multidisciplinary work, which is, and it's so important for all kinds of health professionals to come together, health and development professionals to come together to improve rural healthcare. And pharmacists, including, I think there is a huge role for pharmacists, and there can be task shifting, task sharing. They're part of the primary healthcare teams that work in rural areas. So I think there is a huge value, and I would really encourage you to also connect with Dr. Prathamesh from Dr. RK Prasad's team, who is a doctor in pharmacology and has a keen interest in work in primary healthcare and rural healthcare. So there's a question by Dr. Roshin again on telemedicine. Is it impersonal? So I think it depends on, like everything else, it depends on how you use it. I think in general, it is being used, to my mind, inappropriately. Telemedicine can be a great tool. I mean, telemedicine is ultimately what many of us just pick up a phone and consult someone if you, need additional help. So if it is used judiciously, where it is not a substitute for a responsive, skilled health provider at the front end. If you see it as a substitute, it is impersonal, it is not of value. But if it is seen as an aid to a person, a primary healthcare provider who needs support, who needs consultation, who needs greater kind of clarity in certain things, all of us need that, right? If we see it as that, and which helps in some ways to, the job that typically a doctor can do, a nurse would be able to do, or a specialist, you need a specialized kind of input. So if you use it in that sense with a skilled provider, if you think that it can be done only by telemedicine, the healthcare can be delivered, that becomes impersonal and I would say stupid. So yeah, it can be an enabler, but not a substitute.
Right, okay. I wasn't a big fan of telemedicine until the COVID came. But then I had to change my principles and thinking. Okay. Right. I don't see any more questions coming up. So RK, are you with us? Do you want to conclude now? Just give him a few minutes. I think when we are multitasking, this is what happens. Technology can be a blessing and it can be the opposite. Okay, and I would like to thank everybody. We still have 21 participants with us. So if there aren't any other questions, then shall we call it a day? Thank you very much for your time. So it's been an hour almost, and I think we've managed to finish it. If anybody wants to get in touch with you, I'm sure they can. RK can share your email, particularly the person from Japan, if they want to connect with anybody from your country. So we'll be happy to assist. Thank you very much again for your valuable time and sharing your work with us. It's great. It's impressive, as I said. And I hope you can come back to this forum again with some other areas to answer. Thank you.
Thanks, Hina, and it's been a pleasure.
Thank you. Thank you very much. Good night.
Thank you.
Good night, Dr. Majumdar.